Record it. Okay. All right. So today we are going to talk about the liver diseases and the diseases that includes the biliary ducts. Now, if I had asked anybody about the liver diseases and asking what kind of symptoms a liver disease will cause, everybody would state that, yeah, the discoloration of the skin, it should be some kind of yellow. And maybe in the urine that has to be yellow, or maybe the feces be dark or whiter one. So something that concerns to the bilirubin metabolism. However, not every discoloration is due to some liver diseases. We are going to discuss later on what's going to increase the bilirubin concentration, but you already heard about, for example, in some prehepatic conditions such as the hemolysis, that increased red blood cell destruction will cause an increased bilirubin and will cause a discoloration of the skin. There are some enzymatic tests or enzyme diagnostic procedure that can be obtained in the lab that usually can reflect the function of the liver cells. Some, for example, parenchymal necrosis can be somehow predicted by measuring the acetylcholine transaminase or aspartate transaminase or alanine transaminase enzyme activity, or in some other enzyme that is connected to the biliary duct obstruction, such as the alkaline phosphatase or the gamma glutamyl transferase. Another very important one, as I already mentioned, that the bilirubin metabolism. Whether this bilirubin is a conjugated or unconjugated, whether this bilirubin or the metabolite of the bilirubin in the urine, such as the UBG, urobininogen, or in the feces, how the levels is going to be changed and which is increases further, which is increases less. Another one that usually evaluate the synthetic capability of the liver, such as the albumin, the serum albumin level, certain clotting factor that's synthesized by the liver, for example, or some globulin, or the pseudocholinesterase that again, that is released from the liver. Other liver problem, such as some kind of viral infection or microbiological immunological tests, includes, for example, the hepatitis B surface antigen or the antibody again, the hepatitis C virus, or some autoimmune disorders, so anti-nuclear antibody or anti-RKM or and so on. A lot of antibody could be used to detect some abnormality. Some other materials that usually is metabolized by the liver, for example, ammonium that usually the carbamide cycle, or iron, or copper, or cholesterol, alpha fetoprotease, a tumor marker, or chorioembryonic antigens as well, a tumor marker, and as a lipoprotein that is a LPX, this is an abnormal lipoprotein that can be seen, for example, in obstruction we are going to deal with a little bit later. Other imaging techniques such as ultrasound, that's very, very basic imaging techniques, or ERCP, this endoscopic retrograde cholecystopancreatography, or percutaneous, for example, testis, or CTs, or MRI. And not the last, but the liver biopsy can be used to evaluate the liver diseases, liver functions. Now, before we enter this project, first we have to summarize the normal bilirubin metabolism. This picture is summarizing everything about this bilirubin metabolism. As you know, the red blood cells that stays about 120 days, roughly 120 days in the blood, continuously destroyed and continuously produced. But when the red blood cell blasted, usually by the spleen, that's getting into the reticuloendothelial system, into the macrophage system. What happening there? The hemoglobin is separated from the globin part and the heme part. The iron is utilized and the heme is converted to the bilirubin. Now, this bilirubin is released out from this phagocytic system, and because it's lipid-soluble substances, it's only one way to be in the circulation. It has to be bound to albumin. albumin is going to bind this lipid-soluble bilirubin and transfer into the circulation. Only one organ, only one cell can uptake or can replace the bilirubin or release the bilirubin from the albumin binding, and that's the liver. No other organ is capable to release the bilirubin. Now, what's happening inside, let's see, the liver cells, this bilirubin is conjugated with a glucuronic acid, makes it water soluble, and this conjugated bilirubin excreted into the bile. There are some energy-dependent mechanisms, including the transport mechanism. Usually, this transport mechanism includes the multi-drug resistance transport system and the conjugase activity and the uptake. This all is an energy-dependent mechanism. Now, what will happen? This bilirubin is excreted into the bile together with the bile acid. And this bilirubin, when it's getting into the intestine, this intestine, the bacteria flora, is converting or oxidize this bilirubin to urobininogen and further stercobin and urobilin. Now, this makes the color of the feces. However, as you learn in physiology, due to the enterohepatic, let's say, circulation or cycling, about 90% of the bile and the urobilinogen is getting back to the portal vein. However, when this portal vein, this vein goes through the liver, mostly the bile and the UBG is reuptaken by the liver cells and again is excreted to the intestine. However, a small amount of UBG that is a water soluble, it can pass to the kidney, the glomeruli, and it persists in the urine. So normally what we do have, let's see in the urine, we do have a UBG, and this UBG is formed in the intestine, okay? So it's meaning that we do have an intact, let's see, passage from the liver to the GI tract, and we do have a normal reabsorption. This is one thing, what the UBG means. And we do have mostly a lipid-soluble bilirubin in the bloodstream. So this is the normal bilirubin metabolism. Now, based on the bilirubin levels, the unconjugated and conjugated level, we do have different type of hyperbilirubinemias. First of all, let's mention the bilirubin level. The bilirubin level is very low, relatively is less than 17 micromole per liter. So it's very, very low amount and mostly unconjugated, or this is lipid-soluble one. If the bilirubin level in the blood, the total bilirubin level is higher than 50 micromole per liter, this is the icterus or jaundice. So you can see the discoloration of the skin. It can be yellow. Between 17 and 50, this is what we call as a subicterus, that you can see some yellow discoloration in the buccal area or in the sclera. There is an other symptom that is called the pseudo-jaundice. If somebody eats too much carrot, too much, for example, yeah, or orange that has some carotene, that will give a discoloration of the skin, but it will not color the sclera. If you do have a yellow sclera, this is due to the bilirubin, because bilirubin is going to attach to the collagen, to the extracellular matrix. Now, this is a normal situation when we do have mostly the total bilirubin, and only a fraction is the direct reacting one. Now, in the lab, they're measuring the direct reacting and the total one. The direct reacting means that the water soluble when they are not giving any kind of substances that release the bilirubin out of the albumin binding, and these give a little teeny tiny amount of bilirubin. After they are using, for example, caffeine or other substances that release the bilirubin from the albumin binding, and this is how they measure the total bilirubin. So the normal one, we do have less than 17, but out of this less than 17, the direct reacting is less than 5. Now, if we do have an elevated total bilirubin, so we do have a hyperbilirubinemia, however, the direct is less than 20% of the total, this is what is called indirect hyperbilirubinemia, meaning that we do have mostly unconjugated bilirubin in the blood. The other one, when we do have more or equal than 40% of the total, so the direct is 40% of the total or more, this is called the direct hyperbilirubinemia. Now, based on the intermedicine approach, let's see, so the clinical approach of the bilirubin level, we can talk about prehepatic, hepatic, and posthepatic problem that is going to alter the bilirubin. If we do have a prehepatic problem, this is mostly indirect one because the bilirubin is not conjugated yet. If we do have a posthepatic problem, that mostly is associated with a direct hyperbilirubinemia because the problem occurs after the conjugation. The hepatic problem can be any, either indirect or direct, or another one, this is called the mixed hyperbilirubinemia, when we do have the direct over the total is between 20% and 40%. That's a mixed hyperbilirubinemia. Now, let's see first at the pure direct hyperbilirubinemia, or we call it as a post-hepatic or obstructive jaundice. This obstructive jaundice can happen when we do have a bile stone or tumor or some other things that is going to obliterate the bile duct. What will happen? We do have a normal production of the bilirubin, a normal destruction of the red blood cells forming bilirubin, and these bilirubin are taken by the liver cells and conjugated. However, what will happen? This conjugated bilirubin cannot be excreted, or is excreted, but it cannot transfer to the intestine. So in the intestine, we have no bilirubin at all, no bile. This is why the feces be a colic one. And because we don't have any bile, we have a problem with the fat absorption because the bile is detergent. Okay, and as you see, no bilirubin, no UBG. So in the enterohepatic circulation, there is no UBG. So UBG be negative in the urine. So negativity or less UBG, meaning that we do have an abnormal passage or bypassage to the intestine. However, because this conjugated bilirubin is water soluble, and when the amount of conjugated bilirubin increases, that can pass to the blood and can occur in a free form in the blood. And because water soluble, that can be filtrated by the kidney. So what will happen? We do have a dark colored, dark brown color urine. This is due to the excess of the conjugated bilirubin. So by only measuring the bilirubin, if you do have a direct reacting one, you can think about that possible due to a posthepatic or obstructive jaundice. Now, what other parameters can show that we do have an obstruction? One thing can be some kind of, let's see, enzyme that released out from the epithelial cells of the bile duct, such as the alkaline phosphatase and gamma glutamine transferase. So these enzymes are, it's called obstructive enzymes. Now, alkaline phosphatase, that's a, let's see, a very good and very pure obstructive enzyme. However, in some case, alkaline phosphatase level can increase due to, for example, bone involvement. So this is why in childhood, when we do have an increased bone formation, that the alkaline phosphatase level is higher one. Okay.
Yes.
Now, a question came up, how does the conjugated bilirubin enter to the bloodstream? I think to the this space, when the pressure increases, this is how is going to diffuse into the bloodstream. Now, so alkaline phosphatase can be increased if we do have, for example, bone formation or bone metastasis as well. So if somebody has a tumor that metastasizes to the bone, or we do have an extra, for example, PTH, parathyroid hormonal effect, we do have an increased bone resorption, the alkaline phosphatase level can be increased as well. So keep in your mind that alkaline phosphatase is an obstructive enzyme. However, if you do have an increased alkaline phosphatase level, not due to any obstruction that can be born or during pregnancy, the placenta is a very rich source of alkaline phosphatase. This is why in pregnant women, the alkaline phosphatase level, the normal value, is about double than the normal. So it is normally about less than 100 unit per liter. In pregnancy, around 300 unit per liter. So these are the obstructive enzymes. The gamma glutamate transferase. Gamma glutamate transferase is another type of obstructive enzyme. However, gamma glutamate transferase can be increased due to the alcohol metabolism because the P450 enzyme, when it's activated, the system is activated, the transcription of the enzyme is increased. I think Tornoz already given a lecture about the liver. And this is how you can assume that in alcoholic patient, if the gamma glutamate transferase activity is higher one, yeah, this is drinking alcohol. But not only the gamma glutamate transferase, I'm getting back to this point, but AST level, aspartate transaminase level increases due to the alcohol ingestion as well. Now let's continue. I'm going to say something. If you do have obstruction, the best tool, best imaging technique, when you use ultrasound, first of all, you can use CT, or if it's tumor, you can use ERCP, endoscopic retrograde cholecystopancreatography. However, if the patient has, let's see, a gallstone, cholelithiasis, it's contraindicated to use a ERCP unless this stone is located in the vater papillae and you can remove this stone by this endoscope, because the ERCP can induce acute pancreatitis. A stone itself is a very high risk for acute pancreatitis. Plus, if you use the ERCP, you can again cause acute pancreatitis. This is why this is not used. So ultrasound, let's remember, if you have anything in the intestine, in the stomach or belly, immediately ultrasound, this should be taken. Now, let's see the next one. Okay. When we do have a hemolysis, and that's a pure form of prehepatic problem. If we do have an increased destruction of the red blood cells, what will happen? The hemoglobin getting out from the red blood cells. And as you learn from physiology, but the blood or the cells or the kidney doesn't like the hemoglobin or myoglobin. What will happen to prevent this filtration or this kidney damage? We do have a protein, a carrier protein, the haptoglobin and hemopexin. These two protein is going to bind the hemoglobin, the haptoglobin binds to hemoglobin, and heme is bound to the hemopexin. Now what will happen after being bound to this protein? Not the reticular endothelial system is uptaking it. So in the circulation, if you do have this hemolysis happening intravascularly, the haptoglobin level and hemopexin level will decrease because they are taken by the reticular endothelial system. And they are going to form a lot of bilirubin, but this is not conjugated yet. Now, what is the intravascular hemolysis and extravascular hemolysis? We are going to discuss in the next semester, but let's summarize. If you do have the hemolysis happening in the bloodstream, heptoglobin hemopexy level will decrease. And after, when this binding, let's see, the protein, the bilirubin, uptaken by the rest. When I'm talking about the extra or extravascular hemolysis, is meaning that the phagocytic system directly uptaken the red blood cells. And this is why inside the red blood cells, the bilirubin is released, or the hemoglobin released and forming the bilirubin. So the heptoglobin and hemopexy level is not altered in the bloodstream. So in extravascular hemolysis, there's nothing happening in the heptoglobin hemopexin. In intravascular hemolysis, heptoglobin hemopexy level decreases. Now we do have a lot of albumin that is formed by this reticular endothelial system, but this bilirubin, unconjugated bilirubin, cannot be uptaken because we do have this transport system is saturated. So this is why we do have an unconjugated hyperbilirubinemia mostly. Whatever is uptaken, for sure the uptake is more than normally occurs. We do have more conjugated bilirubin. We do have more conjugated bilirubin excreted to the intestine. And because it's more, the color of the feces is darker. This is why we do have a darker pleiochromic, let's say, feces. More bilirubin, more UBG. So in the urine, we do have an increased UBG concentration. So increased UBG concentration could mean that we do have a increased, let's see, conjugated bilirubin enters to the intestine. Now, what will happen? How do we know that this is happening with the red blood cells? So not only the unconjugated hyperbilirubinemia is the hallmark of this hemolysis, but the lactate dehydrogenase 1 and 2 isoform is released from the red blood cells, and the level increases tremendously in the blood. So this all is going to explain or going to prove that we do have a hemolytic jaundice. Other thing, this hemolysis can be acute or chronic. If we do have an acute hemolysis, for sure, we do have bilirubin in the blood as well, not bilirubin, hemoglobin we can have in the blood as well, further in the kidney, in the urine as well. But an additional things can happen that mostly the hematocrit is going to decrease. Now, if we do have a chronic hemolysis, what's happening? Chronic hemolysis causes anemia. Anemia is triggering the erythropoietin level. So we do have an increased erythropoiesis. So how do we know that the erythropoiesis increased? Because we do have reticulocytosis, because the erythroid precursors enters to the red blood cells, enters to the circulation in the form of reticulocyte. This is what we are going to learn in the next semester as well. Okay, so this is the hemolytic jaundice. In a case of hemolysis or case of, let's see, the obstruction, post-hepatic or pre-hepatic, the liver enzymes are not altered. This is very important, showing that this is not a liver or hepatic problem. Now, let's see what will happen when we do have a hepatocellular problem. Now, as you figure out very easily, how do we know that we have a hepatocellular problem? Because aspartate transaminase and gamma glutamate transferase or alanine transferase level will increase. So we do have an increased enzyme that's released out from the hepatic cells. Now, the two most common enzymes, such as the AST and ALT. AST, or aspartate transaminase, can be found in the cytoplasm and in the mitochondriums, while alanine transaminase located on the cytoplasm mainly. This is why what will happen when we do have a drug or substance that damages the mitochondrium, such as alcohol. When alcohol is metabolized, the alcohol induces the release of the mitochondrial AST. Why? The cells be intact. So this is why in alcoholic liver problem, AST level always higher than an ALT level. However, if you disrupt the cell membrane and the cytosol gets out, ALT always higher than an AST level. This is how you can differentiate the alcohol-induced hepatitis from the viral hepatitis. And in case of viral hepatitis, usually this ALT and AST level is 1,000 times higher than in a normal situation. This is another hallmark of the viral hepatitis. Now, as I mentioned before, there are at least 1, 2, 3, 4 different sites that can be affected in the liver cells. Uptake of the bilirubin, conjugation of the bilirubin, excretion of the conjugated bilirubin, or uptake of the UBG. So these different sites can be affected in different times. So if somebody, for example, has a hepatitis, a cellular damage, if the cell shut down, for sure there is no bilirubin uptake. However, at the beginning, you can have a problem with the excretion of the bilirubin because that's an energy-dependent pathway. Or when you do have a resolution, so when you patient liver cells is healing, and what it meaning that the indirect hyperbilirubinemia is the bilirubin uptaken by the cells, conjugated more, and you do have an increased UBG concentration due to the increased, let's see, excretion of the bilirubin. So how the liver cells gaining back their function, we do have increased excretion of the bilirubin. So this is how everything goes on. But very importantly, when we do have a hepatocellular damage, we do have those enzyme level increases, what we said. Plus, not only the enzyme level will increase, but because the synthesized capability of the liver is altered, maybe less albumin, less coagulation factors. So these all that is connected to the liver cells be altered, including the glycogen, no glycogen store. So this is why the patient could suffer of hypoglycemia. So a lot of things can be somehow show that this patient has a hepatocellular problem. Now, depending on the stage of the liver problem or the hepatocellular problem, the feces can be lighter, darker, so any color can be. Now, this table is going to summarize the classification of unconjugated, conjugated. This is meaning the laboratory diagnostic system. Red one means unconjugated, blue means conjugated. And here you can see the clinical situation. We can have prehepatic, hepatic, and posthepatic problem. You do see the hepatic problem is divided into two parts. If we do have a problem with the uptake or a conjugation, that usually causes unconjugated hyperbilirubinemia. If we do have a problem with the excretion, that will cause a conjugated hyperbilirubinemia, and this is listed what kind of disease is associated with this situation. In prehepatic, mostly we do have the hemolysis or ineffective erythropoiesis that is happening during the erythropoiesis, for example, B12 deficiency or folate deficiency. In uptake, Gilbert disease or conjugated Gilbert disease, or when we do have the absence of the glucuronide conjugase activity, the total one, the homozygosy for the Crigler-Najjar syndrome, that's the lethal one. Or when we do have the heterozygosy form, when we still have some glucuronide conjugase activity, but less, that's the type 2. Physiologic jaundice as well, we do have increased hemolysis, plus we do have a not fully active glucuronide conjugase activity. Impaired excretion can be due to pregnancy-associated cholestasis because the progesterone is altering, let's see, the bi excretion. Or hepatitis, the combination, viral, other microbes, or fungal toxins, or rotor syndrome, or other thing that will cause some hepato problem, but mostly conjugated bilirubinemia. A posthepatic one can be located intrahepatically if we do have a bile duct obstruction that happening intrahepatically, some estrogen, for example, or drug-induced situation, or extrahepatic bile stone and tumor. This can cause this kind of posthepatic problem. Now, let's continue. And this is the summary of the lab diagnostic results based on, again, the place of this problem, prehepatic, hepatic, or posthepatic, or a different, let's see, categories such as the serum, bilirubin, unconjugated, conjugated. In the urine, we do have the bilirubin or not. In the stool, we do have UBG, yes or no. In the serum, the enzyme that I mentioned, LDH, acetalate, alkaline phosphatase, gamma glutamate transferase, or iron or cholesterol level, we already mentioned, and some other, for example, the haptoglobin, reticulocyte, hemostatic parameters, coagulation parameters, such as a prothrombin time and expressed as INR, usually altering when we do have less coagulation factor, or we do have an altered vitamin K absorption, and the gamma carboxylation of the certain coagulation factors is missing. This is why we do have an increased prothrombin time. And that can happen in hepatic reason, or it can be, for example, in posthepatic reason as well. So if you go home and if you dream a little bit about this table, you will figure out very easily what could be the clinical symptoms. One thing about the LDH. LDH has 5 isoforms. LDH 1 and 2 can be found in the red blood cells and in the heart. LDH5, the 5th isoform, found in the liver cells. So this should be kept in your mind. Now, let's start and talk about the hepatitis. You already heard about the hepatitis. There are a zillion types of hepatitis, but mainly in clinical importance, we do have, and this, let's say, named by the letters ABC, A, B, C, D, and E. They used to see that hepatitis A and B, and they had, let's see, after the hepatitis D, and non-A, non-B hepatitis, but now they have C and the E hepatitis. Out of these viruses, only one virus is DNA virus, and that's the hepatitis B virus. Other viruses are RNA viruses. This is how you should remember. And in microbiology, you will learn that the type of viruses and what the name of the virus is. Now, commonly, if you look at the transmission of this virus, so how this virus, the route of infection, you have fecal-oral transmitted viruses such as hepatitis A and hepatitis E virus, these two. And you do have blood or sexually transmitted viruses such as the B, D, C. These are those viruses. Now, the mildest virus, I would say the hepatitis A virus. That's a fecal-oral transmitted virus. They are vaccinating against hepatitis A, mostly the flooded areas when somehow the fecal content is getting into the drinking water, and this is how it's infecting the patient. And that's relatively, it's very short incubation. After a very short incubation period, the typical sign of hepatitis can be seen, so jaundice, fever or subfever. Patient could have a very sensitive liver, but doesn't last too long, maybe 1 or 1.5 months, and the patient cured and they be protected against the hepatitis A. That's so meaning that never ever be a chronic hepatitis is going to develop from the hepatitis A viral infection. very similar to the hepatitis E virus. However, it's only one thing that in pregnant women that can be lethal. We don't know what the mechanism is, but possible a pregnant woman, the immune system of the pregnant woman is altered. And that could cause somehow the protection again or protection of the viruses, so the virus can replicate maybe better way during pregnancy than in a non-pregnant woman. In China, they have vaccination against the hepatitis E virus. This hepatitis E virus was very common one in Africa or Far East and other countries, but today's in Hungary or in Europe, the wild animals infected with this hepatitis E virus. And if you eat uncooked, unbaked wild animal meat, you can be affected or infected by hepatitis C viruses. So almost everywhere you can find this hepatitis C virus now, especially when they are going to bring, let's say, the food from China, from other source. You never know what kind of food you are eating or getting from the supermarket because it can be originated from worldwide. Now, another virus is this long-term history, the hepatitis B virus, and there are several antigens and antibody against the hepatitis B virus. This was studied a lot, and because when they started to use the transfusion, this was the virus that usually caused the biggest problem in the population. Mostly is parenterally or sexually transmitted one. It has a longer incubation period, and usually it takes a little bit longer time that when the patient recovers from this hepatitis B viral infection. And because it could be transmitted through the blood, and donors who gave the blood could be affected and could be transferred to this hepatitis B virus, they started to vaccinate against the hepatitis B virus. And this is why today is very rare the chronic hepatitis that develop from the hepatitis B infection. Another interesting thing, if somebody is infected with hepatitis B, is not the virus is the biggest problem, but your own immune system is the biggest problem, because sometimes when we do have a fulminant infection or inflammation against the hepatitis, your own immune system is killing your own cells. So sometimes if it's a fulminant infection happening, you have to suppress the immune system of the patient, and this way not the whole liver is damaged by your own immune system. But today's the hepatitis B is less common and causes less problem. Now, if somebody is vaccinated, it doesn't mean that they are protected. They have to measure the antibody or an antibody against the hepatitis B. And if they do have a normal or high titer against the hepatitis B, that meaning that is protected. For example, in clinicians or as a doctors, or you as a student, a medical student, you'll be tested whether your immunization is okay or not. And if it's not, they are going to repeat the vaccination. Another virus is the hepatitis D. I started first because hepatitis D is an interesting virus. That's an ineffective virus alone. It can infect only those patients who's carrying hepatitis B virus particles, because it's using the enzyme system of the hepatitis B to replicate. So this is why that's ineffective virus alone does nothing. However, if it super infect, let's say the patient, the carrier of hepatitis B, that can cause infection, or together these two viruses can infect the patient. Now, the vaccination is going to solve the problem, because if you don't have hepatitis B infection, you won't have hepatitis D infection. So this is a good reason. Today's the biggest problem is the hepatitis C. Hepatitis C, as you see here, very common cause of chronic hepatitis, and as an end result of chronic hepatitis, cirrhosis or tumor hepatocellular tumor can develop due to a hepatitis C infection. A lot of cases, hepatitis C infection won't cause acute syndromes, acute symptoms. So there is no jaundice, there is no fever, nothing at all. The patient maybe has a simple flu, maybe a little bit darker urine, and after nothing. But this virus is persisting and living inside the cells and replicating. And after 30 years, when the patient develops cirrhosis or develops a hepatocellular tumor, they're measuring and they're finding out, this patient had hepatitis C infection. Now, hepatitis C or viral infections can be treated. It's no problem. We do have drugs. But the problem is that we cannot realize when the infection is on. If you be tested for hepatitis C, for sure immediately you can be treated. So if you puncture yourself with a needle, who were, for example, you were subtracting some blood from a patient who had hepatitis C infection, and you are putting your needle into your hand, for example, or finger, they are testing. Mostly they are using the PCR technique. And after you be treated, and you won't have, let's see, a chronic disease at all. But whoever doesn't have any symptoms, they are not going to the doctor, and they can develop a chronic hepatitis, and they will develop cirrhosis, and further they will develop a problem, hepatocellular carcinoma. Now these graphs, they're summarizing the antigen and antibodies in the blood due to different hepatitis. Now hepatitis A, for example, that's a mild, let's see, hepatitis viral infection. That is very early, right after the infection. In the feces, we do have an elevated viral level. And as you see here, almost before the clinical symptoms occur, they already, let's see, passing the hepatitis viruses. And when the clinical symptoms occurs, we do have an increased alanine transaminase activity, and later on the bilirubin level increases. And after, when everything is disappears, so everything is cured, the antibody against the hepatitis A virus, first of all, we do have the IgM, and later on we do have the IgG antibody that usually that's be the sign that you already suffered or already exposed to the virus and you already protected against the virus. Why the virus gets into the feces? That's a very good question. That mostly this is how the virus somehow is excreted to the bile system. And this is how this hepatitis A virus is getting into the intestine. So somehow it's getting into the orally, getting into the intestine, and after through the blood, through the enterohepatic circulation, this virus getting into, let's see, the liver, because these are the hepatotroph viruses, only the liver cells infected by the hepatitis. And this is how it is getting out. Now, why the hepatitis B and C and other viruses only, let's see, persisting in the blood? I have no idea. This possibly due to the different surface structure or different receptors or other that is going to mediate or going to rule the binding of the viruses and targeting the different organs and different cells. I would refer to your question to the microbiologist, and you will figure out why that can happen only in the feces, the hepatitis A, why the other viruses can be found in the blood as well. Now, another important one, and this is what is tested in a lot of cases, hepatitis B, because that's a blood transmitted diseases. As you see here, the antigens of the surface antigens or E antigens or core antigens, that's very early, can be found in the blood and not in the feces, usually together with the symptoms. And after this antigen level decreases And later on, the antibody occurs in the blood. So the first time they measure the surface antigen, this is what is called Australian antigen. And this is what they tested, for example, the blood before the patient giving some blood for transfusion. Now, however, before the antibody occurs, the antigen disappears, and we do have a little gap. And in this situation, we still have active replicating viruses in the blood. So these patients who is not detected any surface antigen and doesn't have any kind of antibody against it, they can detect it falsely negative for hepatitis B. Now, this is how they came another antibody or antigen that's a C, the core antigen or antibody, and this is what is called the core window. So this is happening normally. Whoever recovers from the hepatitis B infection, we do have a little gap before the antigen and the antibody, and that's the core window. Here you can detect the antibody against the core antigens. Hepatitis E, let's see, antigen, usually this reflecting the how strongly infective, let's see, the virus is, so how strongly the virus can replicate in the system. If you do have an anti-hepatitis E, that meaning the patient is recovering and the immune response is normal against the virus. E is effectiveness, something that E, so S means surface, core means, C means core, and E somehow the effectiveness. This is how effectively or how strongly the virus can replicate. I would say that could be the E in this letter. Okay, now the previous slide when I was talking about, that was the called seroconversion, when the antigen converted to antibodies. However, if the patient doesn't show the seroconversion, that is a higher chance that the virus is replicating in the blood in the liver cells and causes chronic hepatitis. So there is no core window, and the surface antigen is persisting for a long time. And usually, as you see here, there is no anti-HBe antibody. So there is no antibody, that meaning that this E, as I said, how effectively the virus can penetrate or can replicate, this meaning that the patient be a carrier, so that patient be a chronic hepatitis patient. Now, how can we diagnose hepatitis C? Well, we can measure the anti-hepatitis C antibody. Usually is detectable only 4 to 6 weeks after the infection, so relatively it has a very long, almost 1 month or more than 1 month incubation period. And that is used, for example, in chronic infection, whether it is positive or not. The RNA, the PCR techniques, that's a very sensitive techniques to detect the viruses in acute infection, or viral load can be determined, and very usefully can be used to check how effective was the therapy. Now, the problem with hepatitis C and why we could not develop any kind of vaccination in hepatitis C, because they varies in the genotypes. And another problem, they are changing, let's see, the antigen structure. So this is why it's very difficult to vaccinate against it, because then other virus still can infect the body. So if you're using one type of virus, a second type of virus, but you still have another type of viruses that can infect the body. And the proper therapy, usually it's chosen after determining the genotypes or genetic sequential analysis. And this is how the patient are treated if suffering of hepatitis C infection. Now, autoimmune hepatitis, not too common one, but in chronic hepatitis, if you're counting those patients, about 20% of these patients has this autoimmune hepatitis. Mostly occurs in women. Every autoimmune disorders is very common one in women, possibly due to the altered immune system because during pregnancy. So somehow the pregnancy is a different immunologic environment, and women are somehow, how can I say, it was uh, not developed, but the God maybe somehow invented this girl and the immune system is altered. And this is why the autoimmune disease is very common one in girls. Now, there are two types of this hepatitis, autoimmune hepatitis. The first type, or the classic form, is a frequent one that happening in the age of 20s in girls usually. And that's relatively is a very mild form of the hepatitis, but that's a chronic hepatitis. So it's going to cause a chronic diseases that by the end we do have a cirrhosis. Or the type 2, it's a rare one and usually occurs in children and in early ages. Now, what we do have and what we have to do to detect the autoimmune hepatitis. First of all, we have to measure and increase immune globulin levels, mostly the IgG, that's a chronic form. Autoantibodies in case of, let's see, the first form, so the autoimmune hepatitis type 1, the anti-nuclear antibody or anti-smooth muscle cells antibody, or the anti-soluble liver antigen or liver pancreas antigen can be measured. And in case of type 2, that's happening in early in age, but mostly this patient has a liver kin-3 microsomal antibody. Now, very characteristic histological picture. This is why if somebody is suffering of an autoimmune hepatitis, biopsy should be taken immediately. And another one, we have to exclude other liver diseases, virus, toxins, and other medication as well. So this is why I said liver biopsy is essential to make the diagnosis. And this is how we are treating usually with immune suppression. This is what we have to use. Let's see a case. We do have a 55-year-old man. Medical history only included the hypertension, and what the complaint is cramps in the right upper quadrant of the abdomen. Okay. Measuring, let's see, the lab parameters, we can figure out easily. Every parameters are altered. Every parameters is higher one, including bilirubin, conjugated, total bilirubin, AST, ALT is very high, gamma glutamate transfer is very high, alkaline phosphatase is very, very high. So it looks like there's an obstruction happening. Using an ultrasound, we do have a very much dilated common bile duct, okay, showing that we do have some kind of obstruction. Now, when they do have this ERCP evaluation, the endoscopic retrograde cholecystopancreatography, we are putting the endoscope all the way to the common bile duct. After we put, let's see, the dye into this common bile duct, and we do have, let's see, staining this common bile duct, and you do see that somehow right here we do have some kind of obstruction, and by visualization you can see this papilla and ulcerative papilla, water papilla, dilated common bile duct, and intrahepatic bile ducts. So this is the diagnosis, obstructive jaundice. Now, what they did it during the ERCP evaluation, they put a stent into the common bile duct, and this is why this normalized the blood flow. After intervention, the laboratory parameters showed significant improvement. biliary dilatation disappeared in the ultrasound. Histology of the fatal papilla biopsy samples, immediately you can take by this ERCP evaluation. Adenocarcinoma, CT scan showed no metastasis, so they removed this area, and this is how the patient was cured. And this, for example, a tumor-induced obstruction. Another case, 38-year-old man who was admitted to hospital 1 year ago due to septicemia. When he got blood transfusion, medical history, earlier alcohol abuse and intravenous drug use. He hasn't drunk alcohol for half a year and hasn't used drugs for 3 to 4 years. Doesn't take medication regularly, complains. He has currently no complaints. He was sent to hepatology because of elevated liver enzyme activities during the routine laboratory test. All right, so that could happen. As you see here, we do have an increased ALT, alanine transaminase, or gamma-glutamate transferase, alkaline phosphatase only. And what else they found it? They found that the anti-hepatitis C virus is positive, and in the RNA, they showed that the persistence of the hepatitis C viral antigen. So this patient had, for example, hepatitis C virus. Now, they already started to treat, usually the antiviral therapy, the ribavirin, DA, or the direct-acting antiviral agent, or PED-EF, interferon. We do have a third case, 58-year-old woman diagnosed with cirrhosis 2 years ago, which she probably acquired from her mother parentally as a result of hepatitis B viral infection. Her esophageal varices have been tied off 4 times. She was repeatedly admitted to the hospital because of mental disorientation. Currently, hepatitis B viral DNA PCR is negative. A hepatitis C virus is negative because she already has cirrhosis. She was admitted to the hospital because of strong dyspnea and abdominal distension. So the status during physical examination, tense ascites, hydrothorax on the right side was observed. And as you see, these are the esophageal varices. Look at these are, oh, it's very highly dilated vessels, these endoscopes. Okay, and looking at my ultrasound the liver, you can see as a Lennox cirrhosis, okay, ascites, and looks like the cirrhotic liver. So the granulated inhomogenous liver and ascites, you can see right here. Parameters, white blood cell count decreased, platelet count decreased, AST, ALT increased, blood urea nitrogen increased, okay? Total protein is still at the borderline because 60 to 80, so it's a borderline. INR, so the prothrombin time is increased. Hemoglobin, hematocrit normal, gamma-glutamate transferase activity higher when alkaline phosphatase is higher one, creatinine is higher one, and albumin is lower one. Now here is written what is going to alter the parameters. The white blood cell count and the platelet count possible is decreased because we do have hypersplenia. So due to the portal hypertension, we do have an increased splenomegaly. AST, ALT, and the liver enzyme due to altered liver cells. Blood urea nitrogen creatinine, that's a hepatorenal syndrome. Usually if somebody has a hepatic problem, that can cause a renal problem as well. That's a hepatorenal syndrome. And the synthesis capacity of the liver decreases. This is why we do have a decreased albumin, and the coagulation factor level possible is decreased. Now here, what we do have, that's hepatitis B related cirrhosis and complication of esophageal varices, ascites, hydrothorax, hypersplenia syndrome, pancytopenia, hepatorenal syndrome, hepatic encephalopathy, hyperbilirubinemia, and prolonged prothrombin. So that was the diagnosis. What kind of therapy they can use? Acute care, usually parentheses, so they're removing ascites, fluid albumin supplementation. The diet should be kept this very precisely. Infusion and branches of amino acid, because this is what the liver cannot make. And antibiotics should be used. And finally, the liver transplantation only. This is what they're saving the patient's life. So this was about the case studies and the theoretical part.